So I think it's changing slowly, but when I was trained and for many years of my practice, the teaching was hysterectomy was the solution for fibroids. You didn't have to figure out which fibroid was causing the problem. You didn't have to worry about new fibroids forming, that it worked for everything. And, that if you had severe symptoms, hysterectomy should be at the top of your list. I think that that's an outdated concept, and that for a woman who chooses hysterectomy, there are still good reasons to choose it. But many women don't want a hysterectomy given their experience with surgery. There are women who have no intention of having a pregnancy but want uterine preservation for other reasons. And we need to respect women's choices. And we also need to represent the full range of treatment options. And I think that's, again, where having non-OBGYNs be more adept at early treatment of fibroids. It seems that people who end up in my office would be more likely to have a surgery, and people who end up getting referred to an interventional radiology center that does uterine fibroid embolization may end up getting that treatment option. So just because I don't do it doesn't mean it's not a right choice for the patient. So I think having, again, that dialogue, understanding that while hysterectomy may be a good solution for the OBGYN, it's not always a good solution for the patient. And again, the American College of OBGYN guidance supports all of this, that women should have the right to retain their uterus, even if childbearing is not the long-term goal. We haven't identified any barriers yet, but that's really the whole part of our project two. So project two relates to external barriers, and there's three parts of it. So one part looks at commercially insured women and says, what are the barriers there? So for example, if my health plan says they cover a uterine artery embolization or a medication that uses a GnRH antagonist combination, but the copay for the procedure is $5,000 and the copay for the medication is $1,000 a month. Maybe in reality, I don't have access to those treatments. Maybe they're on paper, but what else is going on? So that's one part. The second part looks at government insured patients and really uses a novel design where we look at paired contiguous states, one of whom underwent expansion during the ACA and one of whom didn't. So to see, did that access provide earlier treatment, better outcomes, or maybe it didn't have any difference, but that potentially could have ramifications at a policy level as well as for patients and providers. And then I think the third thing is to understand how all kinds of providers view barriers. So as I said previously, we're looking not at only at OBGYNs, but pediatricians, family medicine, internal medicine, and not only physicians, but advanced practice providers to say, what are the barriers? Is it that there's a lack of knowledge? Do we need to be doing more CME courses on fibroid treatments for non-OBGYNs? Is there concerns about safety that we need to address? Is it, again, these access issues? Is it that you spend many hours doing a pre-authorization every time you want to do this? And so it's a system barrier. So I don't think we know what the health system barriers are, but it's one thing that we're really excited to look at and we think could have major implications. I think that this is a hard one to answer because that we don't know what women would choose to do if they had equal access to all kinds of treatment. So I think that clearly there have been a lot of surveys that have said Black and African American women prioritize fertility sparing treatments, fertility or uterine sparing treatments, things like that. But I don't know whether that means if the diagnosis occurred early and they got into care early, does that mean that focused ultrasound would go up, or would that go down, or would oral GnRH antagonist combination therapy be more widely used, or are there safety concerns there? So I think it's too hard to predict, but I think the best thing that we would hopefully see short term is women coming in to see knowledgeable providers sooner and following up. Again, I found that some providers say, "Well, nobody's ever told me, that I'm not providing good care, or that they wanted something other than a hysterectomy." Well, just like in every other field of life, a lot of times people won't tell you what they think, but they'll walk out the door and either not come back for a while or seek another provider. So I think that we'd like to see that shortening of time from symptoms to diagnosis, from diagnosis to effective treatment. I would bet that's probably the first thing we'll see, but I think that's down the road for us.